Parkinson's disease is a neurological movement disorder. It affects the brain and causes difficulty with movement, with the most common motor symptoms being tremors, stiffness or rigidity of muscles, and slowness of movement. According to the American Parkinson Disease Association, it is the fastest growing neurodegenerative disease in the world and the second most common after Alzheimer's disease, with an estimated 1 million people in the US and more than 10 million people worldwide living with Parkinson's. In addition to the well-known motor symptoms of tremors, rigidity, and slowness, Parkinson's disease also manifests in non-motor symptoms, including sleep problems, constipation, anxiety, depression, and fatigue, among others, which can be present well before any visible motor symptoms. Dr. Melita Petrossian is a movement neurologist and medical director of Pacific Neuroscience Institute's Movement Disorders Center. In today's episode, Dr. Petrossian discusses these non-motor symptoms and explains the different types of testing that can lead to a diagnosis of Parkinson's disease and what someone living with Parkinson's may need to consider. Hi, my name's Dan Faust, and I'm the host of the Think Neuro podcast here at the Pacific Neuroscience Institute. And I'd like to welcome today Dr. Melita Petrossian. And Dr. Petrossian, why don't you introduce yourself and tell us what you do at PNI?
Thank you. Yes, I am a neurologist and a movement disorder specialist. I mainly see patients with Parkinson's and Parkinson's-related conditions, tremor, gait disorders, etc., along with diagnostic plans, treatment plans with medication. We offer deep brain stimulation programming as well as focused ultrasound at PNI.
And I think one thing I would like to hear from you is regarding Parkinson's patients. How easy or difficult is it to diagnose that? When do people first start thinking they might have Parkinson's syndrome and or symptoms, and how do you figure out that they actually do?
Well, I might take a step back and actually mention what Parkinson's is, because for a lot of people, they don't have a good concept of what it really means. Unfortunately, it is on the rise. So more and more patients are coming in with some knowledge of a person in their life that they have some experience with. But for those patients or listeners who don't really have a good concept of what it is, I do like to start by expressing that it is a neurodegenerative condition that affects the part of the brain that I like to call the autopilot. So the part of the brain that controls automatic movements, spontaneous movements, natural subconscious movements. So for example, arm swing, stride length with walking, the sound and volume of the voice. Some patients, I guess I would say many patients do develop a tremor, but it's important to know that not everybody with Parkinson's has a tremor. And also that the vast majority of people who have tremor don't have Parkinson's. So it unfortunately can get worse over the years, but at the early stages, it can be a challenge to diagnose. Parkinson's can be challenging to diagnose because symptoms can overlap with what patients believe to be normal aging changes, or because if, for example, there's a younger patient, they may identify the symptoms as a neuromuscular problem. So, for example, if we have somebody who has slowness in moving the right arm, for example, and their handwriting is getting cramped and tiny, and it just feels like the signals aren't coming through as quickly, and their shoulder may be stiff as well. And in fact, in patients with Parkinson's disease, the frozen shoulder, which is very common, isn't actually originally a shoulder problem. It stems from the fact that the shoulder joint is very sensitive to changes in the range of motion. So with neurological rigidity, loss of the size of range of motion, the capsule of the shoulder can become adhesive. Like there can be little connections where there shouldn't be, and that nice smooth ball and socket joint can get more stuck and frozen. So people will identify the frozen shoulder symptoms and then subsequently blame all of their hand issues on their shoulder. And if they don't have a savvy orthopedic surgeon who's seen this before, sometimes they may just get chalked up to orthopedic joint issues. And of course, we all have joint issues, right? Like, especially if somebody's in their 50s, which is a very common age for a Parkinson's diagnosis, or even in their 60s, there is an actual shoulder problem or a neck problem, and so they're blaming it on a pinched nerve in the neck or a frozen shoulder. And in reality, it was neurological all along. And it can take a few years before they get referred to a neurologist who's looking for neurological signs.
Yeah, because a frozen shoulder can take a long time to treat, even a non-neurological frozen shoulder.
Yeah. Often people, even with Parkinson's, they'll feel their shoulder did improve with therapy or injections, but then their hand is continuing to get worse. And, again, sometimes, like I said, if there isn't tremor, people may not immediately chalk that up to a neurological problem.
And so, what do you suggest to people? How soon? We also don't want everybody to just run to the neurologist every time they have a pain in their shoulder, right?
That's right. Absolutely. Absolutely. Yeah. That's the tricky thing. A lot of the symptoms that come before a Parkinson's diagnosis or an eventual Parkinson's diagnosis that are actually in hindsight from Parkinson's, they're what we call nonspecific, meaning they're very common. And the majority of people who have those symptoms don't have Parkinson's, aren't on the road to getting Parkinson's. And in addition to frozen shoulder, which is, of course, very common in the population, another common non-motor symptom that precedes the motor symptoms of Parkinson's is constipation. Just to clarify what I mean by non-motor versus motor. So Parkinson's disease doesn't just affect the autopilot and the movements. We like to say Parkinson's isn't just a movement disorder. It also affects what we call non-motor symptoms. So not related to coordination of movement. For example, loss of sense of smell, constipation, anxiety. But again, these are relatively nonspecific because they can occur, in the general population, especially constipation, for example. So while we don't want everybody who has an isolated symptom to rush to a neurologist worrying that they have Parkinson's, there are certain features that do have more high risk of the subsequent development of Parkinson's. And those two non-motor symptoms are REM sleep behavior disorder and the loss of sense of smell. I'll talk about the loss of sense of smell really quickly just to get it out of the way. It's also a little bit nuanced and complicated because if somebody is old enough, they may lose their sense of smell just naturally, where it doesn't immediately mean that they're on the road to developing Parkinson's. It can also be a precursor to Alzheimer's to a certain extent. And obviously, as we saw with the COVID pandemic, a lot of people experienced a viral cause of a loss of sense of smell. And we don't know if those patients are at a higher risk of developing Parkinson's. It was a pandemic, so meaning that pretty much everybody got COVID. So we don't know. That will take a few years to see if that has made a difference. But obviously, if somebody's had a facial injury or chronic sinusitis affecting their sense of smell, that doesn't necessarily mean they will develop Parkinson's. But if combined with other non-motor symptoms or subtle motor symptoms, that loss of sense of smell can be a clue.
It's certainly eye-opening to learn that so many common ailments, such as frozen shoulder, constipation, anxiety, and loss of smell, might be more than they seem on the surface, that they might indicate the presence of Parkinson's disease. Dr. Petrossian mentioned one more symptom that needs to be taken particularly seriously: REM sleep behavior disorder, or RBD, in which people have vivid dreams in which they're being attacked, and they lash out in self-defense, sometimes kicking or punching in their sleep.
REM sleep, REM, that's when we dream. Rapid eye movement is what REM stands for. And during that period of sleep, our eyes are moving rapidly, but the rest of our body is limp or paralyzed. And we can think about that this sort of protects us, that we're not moving during our dreams. Patients who have REM sleep behavior disorder paradoxically do move during REM sleep behavior, REM periods of their sleep. So they are acting out their dreams. They are kicking or punching. Very classically, not universally, but very, very commonly, the dreams are violent self-defense dreams. So I always ask the patients when they come in for a tremor or a gait disorder, do you kick or punch during dreams? And I had a patient who came to me for tremor, and I asked her if she kicked or punched during her dreams. And she said, no, but my husband did. And I said, what? She said, yeah, my husband punched me. And she was really upset about it because she assured me he was a lovely person. He would never do this in his waking hours. And she was so shocked by the fact that he had punched her in his dream. And what I mean by self-defense dreams is that these dreams are classically the dreamer is not the primary aggressor. They're fending off attack, whether it's animals, demons, strangers, but they have to run away from them, yell, push, and I just want to clarify, I don't mean like a little jerk kind of kick. And I don't mean like the legs kind of moving kicking. I mean like throwing a punch, going for a strangle, really giving like an actual appearance of acting out a dream. And so when she told me that, I said to her, the reason why I asked you, and she didn't have Parkinson's. She does not have Parkinson's. I said, the reason why I ask you that is because that can be a precursor to Parkinson's. And she was so surprised to hear that nobody had ever told her that. I mean, I don't even think that he had gotten an evaluation for his dream enactment behavior. And she asked me if I would see him. I said, of course. We obtained a sleep study and it did confirm that he had REM sleep behavior disorder. When I first met him, he didn't have any signs of Parkinson's. And it's a very, challenging thing to, obviously, especially for the patient who's aware of that risk factor, that 80% of people with idiopathic REM sleep behavior disorder go on to develop Parkinson's. And it's a hard thing for them to grapple with. And as a neurologist, to know that this is kind of what they're destined for without being able to do something more definitively about it. But I did advise him that I'd be keeping an eye on him and getting diagnostic testing, which we'll discuss. And eventually things got mildly worsened, and I did diagnose him with Parkinson's disease. But he was very grateful to me for, giving him that knowledge and getting him started on treatment early. I think it's one of those things where people like to share that story because it's so unknown. And frankly, even a lot of doctors are not aware of that. And honestly, I think a lot of people wouldn't think to mention it to their doctors. Like you had a weird dream, you had a bad nightmare. Like, are you going to go tell your doctor? I don't know. But yeah, so that was their story, is that it started with a question I had asked her and something that she almost said almost in passing, and it turned into her husband getting the treatment that he needed.
Yeah, that's really remarkable. How did people figure out that was a precursor, that those sort of fight or flight dreams were related to actually something medically going on, as opposed to something like we think of dreams as being more in the
Yeah.
psychological realm?
That's a history of medicine question I have not looked into because by the time I was in my training, it was already known.
Everybody knew it.
How did they make that epidemiological connection? I don't know.
Yeah, yeah. Maybe it just came up in a Parkinson support
Yeah,
group and
maybe
started
maybe kind
people.
of similar to the sense of smell issue that you start asking people or people maybe volunteered it and then you start asking and then you do the epidemiological studies of well, which how many of our patients who have Parkinson's, if we go back, actually had that problem. And then when you recognize that, then you can start following them going forward. But there's been, yeah, quite a number of prospective studies of people with just REM sleep behavior disorder and, what percentage of them go on to develop a Parkinson's related condition. It's not always Parkinson's disease, but it's in that family. So one thing that is important to bear in mind before we move too far away from the topic is that because the dreams can be quite violent, the bedfellow and even the patient themselves can be at risk of injury. I've had patients who've jumped out of bed and like hit their head on the wall, the bedroom wall, or hit their head on the headboard. I've had patients, give a black eye to their bedfellow, so we do have to consider safety and I'll generally advise people to sleep with a pillow between them, but I definitely have couples where they've decided that they can't sleep in the same bed any longer. And we always advise people to keep anything that could be used as a weapon away from the bedroom. And sometimes I'll have people put padding on their bedside tables so there's nothing sharp near their bed. There is treatment for REM sleep behavior disorder, primarily melatonin. It works a lot of the times, not fully. Sometimes we'll use clonazepam, which is a benzodiazepine, but obviously there are some risks involved with that. So that, would be something that patients should be aware of where, especially if it's happening frequently, like once a week, then they need to be asking for treatment options. Obviously, a sleep study can be really important in most cases to determine and sort of be accurate with the diagnosis because, contrary to, the risk of REM sleep behavior disorder, people who have what we call parasomnias during non-REM sleep, like sleepwalking people who get up in the middle of the night, kind of like, that sort of daze that they're in where they go downstairs and they make themselves a peanut butter and jelly sandwich, that's not it. And there isn't really that risk with that condition. Um, but yeah, it's good to get a sleep study to confirm the diagnosis. And there are other things that can cause REM sleep behavior disorders. So, for example, certain medications. So it does behoove the patient to get a consultation with a sleep specialist to understand their condition further.
Dr. Petrossian said that a REM sleep behavior disorder, known as RBD for short, most commonly takes the form of a violent fight or flight dream, but it's not universal. Doctors need to take into account everything else going on with a patient. Are there other symptoms that might support a Parkinson's diagnosis? Is more detailed testing needed to see if certain proteins are present that might confirm the suspected presence of the disease?
I would say like at least 85% of the time they're describing like violent self-defense dreams. Sometimes it's just screaming or yelling. So that's a little bit harder for me to tell just clinically, but when it's and sometimes they'll use the word kick, but it's more like that jerking movements that we all get during sleep. If you look at a dog sleeping, they get that twitchy, jerky kind of stuff, but that's not concerning at all. That's very benign. So moving towards diagnostic evaluations, I will have patients who get referred to me directly by their sleep specialists. And their sleep specialists have advised them that, you have RBD, you're at risk of a neurological condition, go see Dr. Petrossian. And when they come see me, they don't have any neurological symptoms of slowness, stiffness, tremor, the motor symptoms of Parkinson's disease. Cognitively, they're fine, what have you. Maybe they have something subtle. Maybe they have a little bit of constipation, or maybe they have a little bit of anxiety, or maybe they're a little bit stooped. Their posture's gotten a little bit stooped, but they're also, 65 or whatever it is. So when I have somebody where I don't see any signs of Parkinson's on exam, uh, I I really talk to the patient about their options because not every neurologist feels the same way in terms of how to cope with this population. There's a diagnostic testing that we can perform beyond the sleep study that confirms the REM sleep behavior disorder to determine whether this person exhibits abnormal alpha synuclein that is that precursor to Parkinson's. Alpha synuclein is a protein that is, when it's abnormal, it misfolds and it clumps up and gums up the works in the brain cells and causes the loss of brain cells that cause Parkinson symptoms. So dopamine neurons. But it can be detected in peripheral parts of the body, such as spinal fluid and skin, actually, the nerves of the skin. So we can see positive signals of abnormal alpha-synuclein in the nerves of the skin and the spinal fluid of patients who don't have Parkinson's disease per se, like motor symptoms, but they just have REM sleep behavior disorder. Certainly not universally, but we do believe that those who do have it, then they're certainly at a higher risk of subsequently developing Parkinson's. Whereas if they don't have it, it either means that it's just not present yet, or they may have a different cause of their RBD, and they may be at a lower risk of subsequently developing Parkinson's.
Clearly, there are many data points that neurologists can gather in trying to assess what's going on with a patient. Once they have the information from the sleep doctors, the clinical exam, the scientific tests, and other sources, they need to decide. Do they have enough to draw a firm conclusion? Or, if things are still uncertain, might that cause unnecessary anxiety for a patient? Dr. Petrossian follows a process of shared decision-making with her patients. She explains her rationale for seeking certain assessments and what information she expects to get from doing those assessments, and asks the patient if they're interested in obtaining that information.
Now, some neurologists wonder, well, what do we do with this information? Like, how does it help change guidance? Is it just giving patients unnecessary anxiety? And that's for that reason, it's a shared decision making with my patients. Like I always talk through what the rationale is and what information I expect to get from doing the assessment and whether they're interested in attaining that or not. Right now, the only the only, like, I would say, proven treatment for preventing, well, hold on, let me take a step back. Uh, we really don't have anything that's definitively proven to prevent the development of Parkinson's when somebody's at risk of it. We have good reason to believe that exercise, Mediterranean diet, social engagement, cognitive stimulation, stress reduction, or stress mitigation, I might say, that these things would lessen the risk. But we don't have like really definitive proof. I think we have clearer proof that once somebody has Parkinson's, that exercise slows the progression of the disease. And also that a healthy diet is associated with a slower progression of the disease. So some neurologists argue that, well, if you're just going to tell them to eat healthy and exercise, which they should be doing anyway, like we should all be doing that, then why do you need the testing? And I find that for some of my patients, it's fair to not do the testing. But a lot of my patients feel that they get more motivated to exercise when they know what they're at risk of. And it gives them a kind of a more keen sense of um, knowing what research to be following, what, treatment options might be um, available in the future, and also whether they may indeed themselves want to participate in research. There are a few prospective studies that are enrolling people who just have RBD with no Parkinson's. One of them is through Michael J. Fox. The other one's called the NAPS Consortium. which is a pithy little acronym.
Just a note on all of these acronyms and foundations. RBD, as we've mentioned, is rapid eye movement, or REM, sleep behavior disorder, in which people move and talk during their dreaming sleep. In mentioning the appropriately named NAPS Consortium, Dr. Petrossian is referring to the North American Prodromal Synucleinopathy Consortium. This group is leading scientific research on RBD, including enrolling people with RBD in clinical trials. The Michael J. Fox Foundation is perhaps the world's best-known advocate for people with Parkinson's, named for the beloved movie star who developed Parkinson's at age 30. While the average age of onset for Parkinson's is 60 years old, 10% of diagnoses occur before age 50. Michael J. Fox's foundation provides a community to people with Parkinson's of all ages that helps fund treatments and spearhead potential solutions. Dr. Petrossian notes that research from these and other groups supports the positive effects of diet and exercise, as well as other things people can do.
The point being is that for some people, it helps them, have a stronger sense of the value of their lifestyle choices. So I think that that's relevant. There's a small study that showed that melatonin was associated with a lower rate of developing Parkinson's in patients who have RBD. So I do encourage people to consider the melatonin as potentially disease modifying. Having a sense of how much are we going to worry? If that patient comes back with a little bit of a stooped posture and a little bit of a shuffle, do I want to reassure them that this is just normal aging, or am I going to be really tuning into those subtle things as, this might be Parkinson's, considering what the testing showed? So that's the rationale for, why I do that testing.
And when you talk about the testing, that's the testing for the alpha-synuclein protein.
Correct. Yeah. In the skin or in the spinal fluid.
Okay.
So then if somebody comes with more of a Parkinson's appearance or a do I have Parkinson's or not question, there are other biomarkers that we should discuss as well. But before we do that, again, it's important for people who do have a Parkinson's diagnosis to know that actually the majority of the time, the diagnosis is pretty clear. I would say at least 80% of the time, I'm pretty convinced, just meeting the patient within the first 5 to 10 minutes, I can tell often. It's the way they're moving, it's the way they're talking, kind of the slowness, their facial expressivity. I look at, before I even examine a patient, I'm already examining them. So I'm already observing them.
Right.
How they're communicating. Obviously you and I were communicating just with our heads and shoulders, but in a live situation, I'm looking at their whole body out of the corner of my eye while I'm, ostensibly just asking them about their story. And I'm looking at how they move, how they get up from the chair, how, let's say, one arm is gesticulating and the other arm is kind of curled up in their lap. And those are the kinds of more subtle signs that are very useful to me. And then by the time I get them up and to walk and they're shuffling, their stride length is reduced on one side, they've got, reduced arm swing on that side, and I pull on their shoulders and they fall into my arms. Everything fits together and it's very obvious that they've got Parkinson's. Now, for those 80%, I'll make sure I'm not missing something that could be either red flag for something different from Parkinson's or, something that might muddy the water. So if they have a lot of arthritis and their arthritis is making them stiff and slow, then I'm not going to be able to judge that as easily as if somebody's not dealing with as much arthritis. Or if I have somebody who is, their tremor is kind of mixed. There's a little bit of the Parkinson's appearance of the tremor, which is when the tremor is present at rest. But then when they put their arm out in front of them or they're using their hand, there's quite a lot more tremor. So they might have just a really severe essential tremor, not a Parkinson's tremor. So I'm looking for, are there things that muddy the waters on the exam? Are they taking medications that might make them look like they've got Parkinson's when they don't? Those are the things that I look for. For red flags for atypical disorders, if the person has a lot of speech issues kind of out of proportion to their other symptoms, or they're falling all over the place, um, meaning very frequently early in the course of their disease, if they have an eye movement abnormality, if they have a lot of cognitive issues right up front, these are things that can signify either non-Parkinson's or Parkinson's adjacent conditions. So if I'm seeing or hearing any of those signs or symptoms, then I will definitely get further testing. Often I'll start with an MRI. Now, while the MRI isn't universally required for a Parkinson's diagnosis, again, if there's a lot of cognitive changes or they have vascular risk factors such as atrial fibrillation, then it's a reasonable test to obtain. There is no real consistent marker for Parkinson's on an MRI, but the there are other signs that on an MRI that might point us in a different direction. So, for example, if somebody's had a lot of silent strokes, they might have what we call vascular Parkinsonism, which is a different condition, really. Or if they have enlarged ventricles, those are those fluid-filled spaces of the brain, they might have hydrocephalus. They might benefit from a shunt. Or if they have a lot of focal atrophy on a particular part of the brain, they might be dealing with a different Parkinson's adjacent condition.
But the MRI can help rule out all kinds
And
of
the MRI would rule out all of that, basically.
Yeah.
And that's really what it is. I tell patients the vast majority of people with Parkinson's, their MRI is either normal or normal for age, a couple of little spots and dots and nothing to worry about. Then I also like to make sure I'm not missing any like B12 deficiency or something like that. So that's about it with regards to if somebody's got a classic symptomatology, the progression all fits and their exam fits, then I advise them that Parkinson's is a clinical diagnosis. We don't need further testing. We can just make the diagnosis based off of their signs.
Somewhere in the back of my mind, I feel like I'd heard maybe that through 23andMe can tell you, oh, you are genetically disposed toward Parkinson's. That is one of the things that they can identify maybe even early in your life that you may be at risk of developing later on.
Yes, definitely there are genetic risk factors, but that to me is a completely separate category. What we're talking about now is how do I tell if the person in front of me has Parkinson's rather than how do I tell if they're at risk of developing Parkinson's? So that genetic, considerations are very important, but the vast majority of people with Parkinson's do not have a family history, and the genetic testing tends to be very low yield in those patients, but they have Parkinson's. And the certain Parkinson's genes, the penetrance, which is the term used for the percentage of people with that gene abnormality who actually go on to develop the disease it's associated with, is only about 20 or maybe 30%. So 70 or 80% of those people with those genes are not going to get Parkinson's. So if somebody is sitting in front of me and is asking me, do I have Parkinson's? The genetic test is not answering that question. But I'll explain in a bit why I might obtain genetic testing in other cases. It just doesn't answer the particular question of, are we dealing with Parkinson's right now? So if somebody has Parkinson's signs, but gosh, there's just some things that's muddying the water. Maybe it's their arthritis. Maybe, maybe they had a back issue. Maybe they're on a medication that sort of muddies the water. That's where I'll obtain diagnostic, what we would call biomarker testing.
For the next few minutes, Dr. Petrossian takes us into some of the science behind the testing that can lead to a Parkinson's diagnosis. When she refers to a DAT scan, that's a dopamine transporter scan, a type of brain SPECT, which stands for Single Photon Emission Computed Tomography. Basically, this is an incredibly advanced imaging technique that uses gamma rays to help reveal things happening in the body. Dr. Petrossian notes that PNI is affiliated with Providence St. John's Health Center in Santa Monica, one of the center's hospitals where these tests can be conducted. The SIN1 test is a skin biopsy procedure designed to detect the protein linked to several neurodegenerative diseases, including Parkinson's disease and related disorders.
The three currently available biomarkers are, and I'll go in order of when they got developed, DAT scan, DAT. That's a dopamine transporter scan. That's been FDA approved since 2011. It's a brain SPECT, SPECT. So it's in the family of nuclear medicine, meaning PET scans and such. And so it utilizes a radio-labeled iodine-based tracer, a marker, if you will, for dopamine transporters in the brain. It's done at St. John's and multiple other hospitals across the country. It's something that can be very useful when the diagnosis is unclear, but sometimes there's technical issues. For example, I've seen a case where it came back negative, but there was a technical issue that affected the accuracy of the read. And there are certain medications that can interfere with the absorption of the DAT scan tracer, so affecting the accuracy. So that has to be taken into consideration. The DAT scan, while it's very good, it isn't perfect. So the accuracy, depending on which study you look at, might be, let's say it's around 90%. But the other tests are the SIN1 biopsy, which is, as I alluded to earlier, the way of looking for abnormal alpha-synuclein in the nerves of the skin, and the SAA, meaning seed amplification assay, looking for abnormal alpha-synuclein in the spinal fluid. So when we're talking about somebody who has the motor symptoms already of Parkinson's, and we might say that a more fully developed Parkinson's condition, the accuracy of the SIN1 biopsy and the alpha-synuclein in the spinal fluid is higher, more likely to catch it there. And so that can be useful as well. The specificity tends to be quite high with those tests. So again, accuracy somewhere in that 90% range, very good, but not perfect. Nothing's perfect. So we monitor our patients carefully. We really look clinically at what's going on and try to make a diagnosis with those sometimes 3 points of information.
You want to see those tests before you start administering medication?
Great question, because before 2011, what did we do? If we had a case where it wasn't clear what the diagnosis was, we would just give them the Parkinson's medication. And we would say, well, if you get better, it was Parkinson's all along. And if you didn't get better, it's not Parkinson's. But that's not really that accurate because, for example, if somebody has tremor predominant Parkinson's, they may need a really high dose of medication to treat the tremor. Or sometimes they can't tolerate that high of a dose, and the tremor is just really not getting better. But it is indeed Parkinson's disease. Every medication carries a placebo response, and because Parkinson's isn't just a motor disorder, because it is also very much related to people's stress levels. When people are feeling good, their symptoms are better. So, and sometimes they're better without any other reason. I've had patients tell me that their tremor went away for months initially, and they thought, well, can't be Parkinson's because why would I get better if my tremor went away? But we see that it's intermittent initially, sometimes for really surprisingly long periods of time. So if somebody gets better from a placebo effect of the medication, it doesn't, really correlate with maybe it actually wasn't Parkinson's.
These tests for biomarkers may lead a doctor to prescribe medication, but they may not. The tests represent only one data point that a neurologist considers in reaching a diagnosis and coming up with a treatment plan. Dr. Petrossian walks us through the various information that she weighs as she works with her patients to consider what sort of testing to undergo and what conclusions to draw from it.
Biomarkers aren't necessary for every initial diagnosis, but for cases where, the diagnosis is unclear, it's worthwhile to ask about it. Um, it's important for patients to be careful about, what are they getting themselves into with these tests, because I certainly have patients who have family history of Parkinson's and they worry about it. I had a patient who asked for a SIN1 biopsy from a different provider, like their dermatologist did it. And then she came and saw me and she was like beside herself in agony. And I had to sort of talk her down in terms of, well, it might be a precursor, but I don't see any Parkinson's right now. And so we talked about lifestyle and that kind of thing. I think one question that those neurologists who don't believe in the DAT scan and the SIN1 biopsy might posit is, well, why does it matter? Why does an early diagnosis matter? So on paper, as I mentioned before, the only thing that's kind of proven to slow progression is exercise. So we should be telling everybody to do that anyway. And what I mean by on paper is like in the clinical trials, the treatment that's the mainstay of Parkinson's treatment, which is called levodopa, was not associated with slowing down progression of the disease. So one might argue if you're not sure if they've got Parkinson's or not, you can wait until their exam worsens, their symptoms get worse, and then you can start the treatment when their symptoms are worse. And there's some rationale for doing that. But there's also some cases where if people wait too long to get started on treatment, anecdotally, I would say I've seen where they don't do as well with their treatment, like especially if they just never got diagnosed in the first place. Like it wasn't even a consideration. Like these patients who have a lot of their hand is stuck and clenched and tight, like a dystonia almost, or actually not just almost, but literally a dystonia, meaning an abnormal posture of the hand and their fingers getting clenched. So let's say there's a patient who has a lot of dystonia, their hand is clenched, and they never thought that they had Parkinson's. They were being treated as some kind of shoulder issue, joint issue, et cetera. And 5 years have gone by. It's not as easy to treat that. That clenched hand can be kind of stuck like that. So there is a rationale for treating people early. There's another medication that's a milder medication that is a little controversial. It's the class of medication called the MAO-B inhibitor that some studies showed that it would slow progression of the disease, whereas others did not confirm that. So I like to tell my patients, if you ask 3 different neurologists, you'll get 4 different opinions. But I do believe that that class of drug probably slows progression of the disease. So unless there's some medication interaction issue or other contraindication to that class of drug, I do like to start that, especially when it's an early stage. It's a very mild medication. It doesn't like have dramatic effects. So, it's something that patients feel really reasonable about taking because it's an easy medication once a day kind of thing. So in those scenarios, I think the idea is that it does matter to have an earlier diagnosis. So I think psychologically, it really matters to know what you're dealing with, to get yourself a path, to know which path you're going to go down and how you're going to cope with that. I think rather than kind of having your blinders on.
Well, certainly it can be so stressful not knowing all that time waiting. So sometimes it's better to know even when it's unpleasant news. But
Exactly.
I think also to your earlier point, when so many of the things that you do know that are helpful are exercise and diet and stress reduction, which are going to be good for any of us in any type of scenario, you might as well get started on that.
Yeah, kind of more diligently, I think. But just to answer your question about the genetics. So, I do think that If I have a patient with Parkinson's and they have a strong family history, I do encourage them to get genetic testing because then it's pretty high yield that we might find something there. And there's two particular genetic subtypes of Parkinson's. One is called GBA and the other one's called LRRK2. LRRK2 is spelled LRRK2. And both of those genes are more common in the Ashkenazi Jewish population, but they're also fairly prevalent in non-Ashkenazi Jewish and really across ethnicities. And though both of them have, as I said, a limited penetrance, the majority actually of people with those genes do not get Parkinson's, because it can run in the family, and because there is that consideration of understanding what people's risk factors are. I think that if somebody already has Parkinson's, I might do the genetic test, not to say, do you or don't you have Parkinson's, but rather to say, is there a genetic contribution to this disease? And what could that relevance be to your family? Number one. But more importantly, is there a genetically inspired treatment that would be more of a personalized treatment for you that's more specific in the context of your genetic cause of Parkinson's? And the other reason why I sometimes will obtain it is because there's reason to believe that certain genetic subtypes carry a different prognosis of the disease. So sometimes if I have somebody who's not doing well and I don't know why they're not responding to treatment and they have a family history, I might say, let's do a genetic test, and that might help us understand what's going on better. So there's a lot of research happening right now to find treatments that are, I like to call them genetically inspired, where what's interesting is we don't know yet whether only the people with those genetic abnormalities will respond to those treatments, or if they may actually be useful for people with any cause of Parkinson's disease. So people who have the disease and genetic subtypes of it might be interested in participating in various clinical trials available now to answer that question. And then a family member, let's say an adult child who worries about their risk, it's up to them to decide whether they want to get genetic testing or not. But if they do, as of right now, we don't have clinical trials that are enrolling people who just have the gene without the disease, at least not locally. But that might be something that will be relevant in the future. So I always tell people, why don't you get tested? Because if you come back negative, then the conversation's done there.
Mhm.
I don't need to worry about anything. But if you do come back positive, then, we can ask for genetic counseling to help you figure out how to communicate this to your family. And then them to decide whether or not they want to get tested.
And if you come back negative, it doesn't mean you don't have Parkinson's. You might still have.
Exactly.
Right?
Yes. If somebody has Parkinson's and their genetics are negative, it just means it wasn't a genetic cause, that it was more of an environmental cause. There's a lot more Parkinson's happening right now, and we believe that it's not our genetics that are changing, it's their environmental issues. But generally speaking, we believe that even with a genetic predisposition, as I mentioned, if the penetrance is only 20 to 30%, then there has to also be an environmental cause that translates that risk into the actual disease.
And
And
what could be those environmental causes?
it's a whole other podcast. There's a great book that's very enlightening, but also very terrifying, called Ending Parkinson's Disease, by Ray Dorsey and 3 other authors. That's got a ton of information about environmental causes. I highly recommend that one. I think the other genetic question was, so what if we have somebody who has they're adult, a child, and they have a non-specific symptom like constipation, for example. If they have a family history and they tested positive for a gene, then that's somebody you're going to keep a closer eye on, or maybe they themselves will keep a closer eye on their symptoms. Or if they start noticing a little change in their handwriting, maybe they'll get checked out sooner. So it's not unreasonable for people to go do 23andMe, but I like to ask people to be careful with that. You kind of want to know why you're looking. What are you going to do with this information?
So I just want to, I'm just going to step back and try and maybe reiterate some of what you said, but it sounds like there's that diagnosing someone with Parkinson's or with a Parkinson's related uh, disease or it would be there's almost as much art as there is science to it. Like you said, that moment when they walk in your office and you can see a certain number of things and can kind of tell, and then there's the other trying to just pull together all this case history, all these different things, and do they all add up to a Parkinson's diagnosis?
Correct.
Sometimes with these actual, scientific tests, which are just, it's all just more information.
Yeah,
You know,
exactly.
some diseases, it's very clear you want to catch that as early as possible. The jury may be out on Parkinson's, but there definitely are things you can do if you catch it earlier to slow the progression or reverse some of the symptoms.
I think the jury is pretty clear that it's very important to diagnose Parkinson's early, but I think the jury's out on what to do with patients who have RBD and are at risk of Parkinson's. How much testing do you do in those? But I encourage people to check out Michael J. Fox Foundation for the prospective work that they're doing to, create a more prospective biomarker. We sort of see it developing, and we want to, this is a really important population, I think. And it's very unique, honestly, because, as opposed to Alzheimer's, where we all have our senior moments, right? Like all of us. What was, I forgot to, pick up the bread from the grocery store, right? Like,
Where's my car?
where did I park my car? Yeah. Absolutely. So those things are so widespread that it is by the time you've differentiated between, this one was actually Alzheimer's all along versus this one's just normal, you know, a number of years have passed by, and it's just so challenging to know, looking at that person, are you going to get Alzheimer's or not? Whereas with Parkinson's and RBD, especially if there's SIN1 biopsy or alpha-synuclein seed amplification assay, and their spinal fluid comes back positive, you know what you're dealing with. This is a person who's at very high risk going forward. Not universal, some people stave it off, but they live
Yeah.
long enough with it. They're very, very, very likely.
And maybe just one more question about those tests, but maybe one reason you might be a little slow to order those tests would be because it's
And
not a pleasant procedure necessarily.
nobody's minded the SIN1 biopsy.
Uh-huh.
Our nurse practitioner does it. She's been doing it since 2020. And, obviously there can be a minor scar. It's 3 millimeters in 3 locations. It goes maybe 4 millimeters into the skin. Then it just heals on its own. We've had 1 or 2 cases of delayed wound healing, but it's really an easy procedure for them to undergo. Nobody's really been too bothered by that. But the spinal tap, people don't like the idea of a spinal tap. It's probably not as bad as people think it's going to be, but nobody wants to sign up for a spinal tap. Spinal fluid is a very important fluid for neurologists, but it's sort of gotten downplayed lately. I think people are looking for, more non-invasive ways of doing it, right? Everybody thinks the MRI is going to tell us everything, or the PET scan or something like that. So spinal fluid, it used to be called the neurologist's blood draw. So it used to be very, very routine. Like we draw blood and spinal fluid, So it can be a little bit uncomfortable, and there can be headache afterwards. But if it turns out that as a prospective biomarker that we can predict how the disease is going and monitor it over time using spinal fluid, we may end up using more of that. I would love to see it in blood because nobody minds a blood draw. And I always tell people what we need is a prospective biomarker.
And that's when you say the prospective work that the Michael J. Fox Foundation is doing to see if that spinal fluid will ultimately become that.
Or other tissues. But yeah, definitely, Michael J. Fox's kind of foundation's big push is for that prospective biomarker. They've been what I was mentioning earlier about the database or the registry that they ask for RBD patients to participate in is called the PPMI, which stands for Parkinson's Progression Marker Initiative. And I don't even know how long it's been going on for. It's been going on for a really long time. And the point being is that they're obviously not the only people who are working on this, and they obviously do it in collaboration with universities across the country, but it's a very, very big push.
Great. And the drugs have been around for a long time. I'm thinking about Oliver Sacks. I'm thinking about, and
Well, and
Awakenings, but that's decades that there have been some of these drugs, and I don't know how well they've advanced or how well the modern
there's definitely been
imaging
advances
have.
in how we deliver those drugs. So there are, in the last year, 3 new medications for motor treatment, and even more if you go back a decade. So there's definitely been advances, for sure, but nothing that comes to like a cure. Not yet.
Yeah.
There's work being done for sure.
Thank you very much for sharing all this great information with us. And I think it's really going to help a lot of people on their journey and at least know what to talk to their doctor about and whether they should see a neurologist.
Thank you so much for having me. This was really great.
Sometimes we want simple answers from our doctors. Do I have a disease? What can I do about it? In today's episode, Dr. Petrossian showed us the complexity of Parkinson's disease, how the journey to answer those simple questions often involves many difficult decisions. Yet she also gives us hope as we continue to unravel the mysteries of this disease, learning how to identify it, what we can do to slow its progression, and how modern medicine is finding new treatments that can help. Perhaps the Michael J. Fox Foundation put it best in defining its core values: optimism, tenacity, collaboration, boldness, adaptability, and curiosity and problem solving to work on behalf of the millions of people around the world who are living with Parkinson's. This is Dan Faust, and thank you for listening. Please join us next time on the Think Neuro podcast.